Thanks everyone for joining us. So I have the pleasure to introduce Dr. Zupancic. He's the Associate Professor of Pediatrics at Harvard Medical School and the Associate Chief of Neonatology at Beth Israel Deaconess Medical Center. He serves as the Director of the Exploring Pathways to Optimize Child Health, or the EPOC program, directing clinical research at Beth Israel Deaconess. His scholarly work focuses on epidemiology and health services investigations, including economic evaluations, randomized control trials, and the Neonatology Canon Project, which is a large-scale systematic review of randomized control trials in neonatology. Many people here may also know him from his 52 and 52 RCT trial challenge, which has just recently been published as a book. So there's a plug for that. And he was also involved in this trial, involved in the secondary analysis of this trial when Dr. Gyamfi-Bannerman published an economic evaluation. So welcome, Dr. Zupancic.
Thank you.
It's great. And for all the audience, Dr. Zupancic was, and his 52 and 52 was the inspiration of starting this whole thing. So that's where the seed was planted. With that, I'd like Matty Wolf to introduce Dr. Bannerman.
It's my pleasure today to introduce the lead author of this study, Dr. Cynthia Gyamfi-Bannerman, who's professor and chair of the Department of Obstetrics, Gynecology, and Reproductive Services at the University of California, San Diego. She's a board-certified maternal fetal medicine specialist and internationally recognized for her work in obstetric complications with a primary focus on preterm birth. She's also a perinatal epidemiologist with a Master of Science degree in biostatistics and answers clinical questions using available clinical data. She has leadership roles with the American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine, and has co-authored numerous clinical guidelines for obstetric practice. She's led multiple clinical trials and published numerous peer-reviewed articles in the New England Journal and JAMA, such as the one we are going to discuss today. We're so excited for you to join us. Welcome.
Thank you so much for having me. Appreciate it.
All right, so with that, I am going to share my screen. And then we'll go ahead and get started. So again, thank you for the opportunity to be able to present this follow-up study, the ALPS follow-up study, looking at neurodevelopmental outcomes after late preterm antenatal corticosteroids. So to
Charise,
start,
can you?
yes.
I
Sorry.
I don't see like just the slide. I see your whole presenter view. Just.
See. Great. Is that better?
Yep.
Perfect.
Yes.
So to start with, we will review the consort format, which is a checklist that helps with organizing randomized controlled trials. We'll come back to this checklist at the end after we review all of the details from the study. So as I mentioned, we'll be reviewing the ALPS follow-up study, which was published this last April. Before we get into the follow-up study, I think it would be helpful for us to discuss the original parent randomized control trial of which the ALPS follow-up study is based on. So the antenatal betamethasone for women at risk for late preterm delivery was published in April of 2016 by Dr. Gyamfi-Bannerman. It was a multi-center, double-blind, randomized control trial with a one-to-one enrollment, meaning that for every patient that was enrolled in the intervention or in the betamethasone arm, there was another participant enrolled in the control arm. And participants in the study were also consented for further research as well, which is where the follow-up study comes in. I really like the PICO format to help with organizing the primary findings of a study. So for P stands for participants. So in the ALPS trial, the participants were women with singleton pregnancy at 34 weeks, 0 days to 36 weeks, 5 days, who were determined to be at high risk for delivery. And this was determined by several patient characteristics, including dilation and effacement, spontaneous rupture of membranes, etc. The I stands for intervention, which was 2 injections of betamethasone separated by 24 hours. C control were 2 injections of placebo administered 24 hours apart. And the outcome for the original ALPS study was composite respiratory needs, which included the use of CPAP or high flow nasal cannula, the requirement for FiO2 greater than or equal to 30%, ECMO or mechanical ventilation within the first 72 hours of life, and stillbirth or neonatal death within the first 72 hours of life. There were over 24,000 participants who were assessed for eligibility. Ultimately, the majority of these participants were determined to be excluded and not meet eligibility criteria, with the most common reason being the expectation for delivery within 24 hours. Ultimately, a little over 2,800 underwent randomization, and then in each group, there were about 1,400 participants in the betamethasone group and the control group. As far as baseline characteristics for the intervention or betamethasone group and placebo group, they were overall pretty similar as far as their indication for delivery, gestational age. However, there was a slightly younger group in the placebo group as far as maternal age, and there were more Hispanic mothers in the placebo group as well.
So, Dr. Bannerman, this is a good point to interject. Can you walk us through how you went about designing this trial? What was the knowledge known at that time, and how were the outcomes chosen? And how do you got to agree so many people to do this trial? Was there an equipoise at that time?
Sure. No, those are all excellent questions. So we designed the trial kind of very, very specifically. First, we used the same betamethasone dosing and everything as Liggins and Howie. This was actually one of the first steroids trials not to tocalize, because we didn't want to test 2 interventions and not know which one was going to be the most helpful. But also, if you imagine that we had to design a trial in which we were fairly certain that the participants would deliver between 34, 35, and 36 weeks. So we had very strict criteria surrounding preterm labor, because as you all know pretty well, we have no idea when someone comes in preterm labor if they're going to deliver. We're actually terrible at that. So they had to be very, very dilated, but then not too dilated that they would deliver right away. So it was kind of between like 4 and 8 centimeters. PPROM was all indicated as long as whatever the obstetrician felt, but it was very important to have a cohort of people that would deliver in that period, and not a cohort of people that would just go on to deliver at term, where the incidence of your primary outcome becomes lower and lower. The composite was another one that we really looked to you all to help us with. And so we spoke with several neonatologists around the country. I'm remembering Brad Yoder. We worked obviously with Lucky Jane. We worked with a lot of folks. And we wanted to design an outcome that was serious enough that the infants would end up in a special care nursery, whether that was the NICU or some kind of special nursery where they would not be with the mother at birth. And so that was the consensus of the neonatologists we consulted with, and then obviously had a more severe outcome that we chose in terms of just increasing the amount of respiratory support. And then finally, I think your other question was how we were able to, encourage these numbers of women to participate. We, within the MFMU, always assume that about 50% of pregnant individuals who are approached for a clinical trial will say no. And that's for a variety of reasons, but particularly pregnancy in and of itself, some people are not willing to participate in clinical trials. So we assumed about a 50% consent rate, and we actually got that, maybe slightly higher than that. But I can tell you, and this is totally an aside, but the best way to encourage a lot of participation is to have excellent CRCs that look like the patients that we're serving. And so our research coordinators, I mean, at Columbia, where I was at the time, I think there's not a single one that was what you would classify as white. We had a lot of Lebanese, we had Black, we had Hispanic, and particularly in Columbia, where there's a lot of Spanish-speaking patients, it was wonderful to have Spanish-speaking CRCs. So that was really a way to get a diverse group, which I'm glad that we were successful too. And I think I answered all your questions, but if I did not, feel free to ask.
In the OB world, was there any equipoise regarding the beneficial effects of late steroids in late preterm population at that time?
Yeah, I would say that even less than equipoise, there were really no data. I mean, we had some preliminary data from Liggins and Howie, so back in the 70s. But we hadn't really had any other studies, at least not published by the time that this paper or this study was conceived of. We didn't really have any other data, but we had no concern at all that this would be harmful. And so it was studying an intervention in a different group of people. But yeah, so there wasn't really any, I wouldn't call it equipoise because, you know, no one was saying, well, maybe we should do this, maybe we shouldn't. It was kind of like, let's study it and see what happens.
Thank you so much.
And I have a couple of slides on that a little bit later. So great. As far as the primary outcomes, so the primary outcome of the composite for a need for respiratory support within the first 72 hours was improved in the betamethasone group compared to placebo. As far as severe respiratory complications, those were also lower in the betamethasone group. Need for resuscitation at birth, transient tachypnea of the newborn, bronchopulmonary dysplasia, need for surfactant, as well as a composite of respiratory distress syndrome, TTN, or apnea. All of those outcomes were less in the betamethasone group. As far as number needed to benefit, so taking the inverse of the absolute risk reduction for the primary outcome, 35 mothers would need to be treated with betamethasone in order to prevent one respiratory morbidity. Looking at the secondary outcomes, these were all fairly similar between the betamethasone group, except for hypoglycemia. So hypoglycemia was significantly higher in the betamethasone group compared to placebo, with about 24% of the betamethasone group experiencing hypoglycemia compared to 15% in placebo. One interesting thing as well in that setting was that those who received betamethasone also had a decreased median time to first feeding, likely related to the betamethasone, or related to the hypoglycemia rather.
Dr. Zupancic, as a neonatologist looking at these primary and secondary neonatal outcomes, can you give your thoughts on this data and what comes to mind?
Yeah, I have a couple of thoughts. The first is that, you know, this study definitely highlighted the difficulty with examining outcomes in the moderately preterm population, because I think for most neonatologists, seeing the positive, the beneficial outcomes, it brings up the idea that many of those outcomes are, for us, not actually all that severe. They are problematic in the sense that the baby has to be admitted, but most of what we were seeing were very treatable outcomes. And I think that even when they were labeled severe, right? So you're on high flow nasal cannula, you're on CPAP, but the large majority of those babies are going to be expected to get better. And I think that's one of the things that has scared people off from studying the moderately and late preterm populations, and it's also a rationale for the follow-up study that Dr. Bannerman did. So I think the first thing I would raise is this idea that, maybe for the moderate and late preterm populations, we need to really think about what sorts of outcomes are going to be compelling for us to change our practice. Is it really going to be admission to the neonatal intensive care unit? Is it going to be long-term outcomes? And I think in this case, we'll probably come back to that part of the discussion as we look at the follow-up study. The second thing I'd say about the outcomes is, and Charise, you might actually be thinking about this, but you calculated a number needed to benefit. Did you do a similar calculation for the adverse outcome of hypoglycemia? And if so, what do you think about the relationship of those two calculations?
I did,
Look at
yeah.
the screen.
Oh, perfect.
You were right ahead of me.
I'm sorry.
Exactly. So taking a look at the number needed to harm for hypoglycemia. So in this case was 11. And for a lot of the same things that you already said, Dr. Zupancic, I consider respiratory morbidity to be a more severe outcome than hypoglycemia because hypoglycemia is so treatable. One thing I was thinking about was it would be helpful to know like the degree of hypoglycemia. Was it severe enough to like otherwise require NICU admission based on that particular unit's culture, as far as like admission to the NICU for late preterm? Was it treatable with just starting feeds earlier, which it seems like the infants in the betamethasone group did have a lower median time till their first feeding. So I don't know if anyone else has any other thoughts on that.
Can I ask one
Question for
more follow-up question?
Yeah.
go ahead, John, and then I have a question for Dr. Gyamfi-Bannerman.
I was wondering if you had thought about a way to combine the two numbers needed metrics. Can you think about any sort of a quantification of the weight of a positive and negative outcome? I think this is potentially something that we should be doing more in neonatal.
I would think in a multivariable logistic regression, you could include those outcomes and then be able to weight the degree of hypoglycemia and weight the degree of respiratory morbidity, and then have some sort of outcome related to those things, such as like duration of NICU stay, need for admission to the NICU, or an intermediate care nursery.
Yeah, I think that would certainly be a very kind of rigorous way to approach that, and I agree. The other thing I think that we could start talking about is just a ratio of number needed to benefit and number needed to harm, or number needed to reconsider, perhaps. So you have a number needed to benefit of 35 or 36, and a number needed to have one hypoglycemic baby. That essentially means that there's, for every baby who benefits, there will be 3 babies who are hypoglycemic or are potentially harmed, and that ratio starts to allow these outcomes to make more clinical sense, I think for people. So if you just take the two and put one over the other, I think that's a powerful metric that we're underusing.
Yeah,
Before we move on from outcomes, I wanted to ask Dr. Gyamfi-Bannerman about when she was talking about the selection of the outcomes, she mentioned talking to neonatologists, and I think perhaps it was different not too long ago, but I think nowadays it's becoming very popular, and I think it's the right decision to also involve parents and families in the decisions around what outcomes to choose. And I'm wondering, was that at the time of this trial being designed, were there parental representatives involved in making the outcome selection? And I think that speaks to what John was saying about the difficulty of picking the right outcomes for this population.
Yeah, so a few things to say. First of all, the questions that were raised, there's a secondary analysis that I put in the chat, if you all can see that, where we actually addressed all of those, because I think it was really important to answer that question. And because hypoglycemia is a common outcome in late preterm infants, which we really need to understand, what is that level of risk? And I think, as you pointed out, it was mostly treated with feeding and resolved pretty much right away. So was it that harmful in terms of what we think about hypoglycemia when we think about babies with kind of neurological outcome issues, or is it that it was transient? And in that paper, so we actually went back and reviewed all of the charts of the infants. I would say 92% of the charts of the infants enrolled in the original ALPS study. And within that, we found that while looking at all of the hypoglycemic infants in both arms, we found that the hypoglycemia for both groups had pretty much resolved within 3 days. But for the groups that received steroids, it mostly resolved within 6 hours. So it was really transient, brief. Most of them were not treated with IV. Most of them were just treated with feeding. And so that paper was published a couple of years back, but really kind of reviewed those because we wanted to see, when people think of hypoglycemia, obviously they think of a lot of different elements, but in looking at that, we really wanted to make sure that this was a very transient finding. And so that was the case for the ALPS trial. And again, not as bad in the steroid group. With regards to your other question about, families being involved. So this is an NICHD MFMU study. And when we designed it, certainly back in 2010, 2009, it wasn't really that, as it should have been. It wasn't really that common to have families involved. In fact, I don't think still we have at the MFMU level that type of representation in the studies that are being designed. So it's a great thought. It's funny, I was the one who I remember very vividly saying we should include hypoglycemia as an outcome when we were sitting in the room discussing it, just because of how common it was in late preterm infants, but not at all because I thought that there would be a differential there.
Yeah, some very thoroughly thought out outcomes. For Charise, can move forward.
Great. So we kind of talked about the effect of hypoglycemia both on families and the potential need for NICU or intermediate care admission. But the respiratory morbidity associated with RDS and TTN also has cost to that as well. And so Dr. Bannerman, as well as others, published the study back in 2019, doing a cost analysis looking at maternal infant pairs and costs associated with betamethasone administration, as well as NICU care or newborn care. And they were able to show that there was actually a cost reduction in the betamethasone group compared to the control group, with an average cost of about $698 per pair, which I think is also important in this conversation as well about healthcare costs and betamethasone administration being a cost-effective way to improve newborn outcomes. I don't know if anyone had anything to add on this. All right, so we'll move forward then with the ALPS follow-up study. And so we know, much like we have already talked about, that antenatal steroids benefit those premature infants who are born before 34 weeks. However, there was not prior to the ALPS follow-up study a lot of good data on neurodevelopmental outcomes for these infants. There is some preclinical data that suggests adverse outcomes. However, this follow-up study was really important in addressing children who were exposed to antenatal betamethasone and what their ultimate neurodevelopmental outcomes became. So the study authors hypothesized that children who were exposed to antenatal betamethasone would have a decreased frequency of cognitive function, 1 standard deviation below the mean, or less neurodevelopmental impairment measured at age 6 years or older compared to children exposed to placebo. This was a prospective follow-up study of the prior mentioned multicenter double-blind placebo-controlled trial, which included 17 MFMU or maternal fetal medicine units, centers of the NICHD from 2010 to 2015. Using the PICO format, again, the participants' intervention and control in this follow-up study were the same. However, the measured outcome was neurodevelopmental impairment using the General Conceptual Abilities Scale with a score less than 85 on the Differential Ability Scale, or the DAS-2, for children age 6 or older. There was also a secondary analysis of gross motor function classification system level, as well as social responsiveness scale, which looks at measures of autism and the child behavior checklist. Parents signed a physical consent form, and children either provided verbal or signed assent based on that individual institution's IRB. Study visits were performed at the clinical center, the participant's home, or at another agreed upon location. Again, the study outcomes were cognitive testing performed by a licensed psychologist with the DAS-2, looking at measures of cognitive function such as verbal and nonverbal reasoning, and reports a general conceptual ability score and a cluster score. The GMFCS was also looked at, as well as parent-performed scales, being the social responsiveness scale, the child behavior checklist, and looking at general health of these infants as well. The study outcomes looked at the proportion of children with GCA scores less than 85, which was determined to be 1 standard deviation below the mean. And then the secondary outcomes, as we listed here. One thing I did want to mention about the GMFCS score was the secondary outcome there was a score of greater than 1, which indicated any need for assisted ambulation. The guardians, research staff, and investigators were blinded to treatment assignment in the original ALPS study. But again, this is a follow-up study, so there wasn't, of course, any blinding in the follow-up study. As far as statistical methods, we'll take a look at some of the baseline characteristics from the follow-up study. The authors also conducted log binomial regression as well as a quantile regression, which I'll talk about in the following slide. The authors also did a post hoc subgroup analysis, as well as sensitivity analyses to look for any differences in those who did or didn't follow up or were or were not included in the study. I did want to take some time to review log binomial regression because this was something that was new to me. And so it's a generalized linear model that uses logistic regression and creates a binomial distribution. And it's especially used for situations where there are 2 categorical variables or continuous variables. It reports risk ratios instead of odds ratios, which helps with interpretation and helps with being able to calculate number needed to treat and number needed to harm. As far as quantile regression, this is a type of regression analysis that estimates the relationship of the independent variable to specific quantiles of the dependent variable, where typically we would think about a linear regression or a log regression measuring the mean of a dependent variable. As far as participant flow and sample size, so we mentioned that in the original parent trial, about 2,800 birthing parents and their infants were included. For various reasons, there was dropout in this number, and ultimately 2,400 were determined to be eligible for the follow-up study. Ultimately, about 479 in the betamethasone group, as well as 470 in the placebo group, were included in the primary analysis for neurodevelopmental outcomes. As far as recruitment for the original ALPS study occurred during October 2010 to February 2015. There was a brief period of time during the original ALPS study where the trial was paused due to a change in the manufacturer of the placebo. The neurodevelopmental follow-up study then took place from 2017 to 2022. Before we get to the results of the follow-up study, I did want to take a moment to mention some controversy in the field, especially as it relates to late preterm infants in the administration of antenatal betamethasone or corticosteroids. The ASEX-2 trial was a trial that began in 2005 and actually published while the ALPS trial participants were conducting their trial, looking at steroid administration compared to usual care for those who went on to have a term scheduled C-section. And they found no difference in parent-reported neurodevelopmental outcomes, but they did find a higher percentage of infants who were exposed to betamethasone showed decreased school assessed performance. An additional meta-analysis looked at various randomized control trials and observational studies for those delivering in the late preterm period who received steroids and determined that there was a decrease in the risk for severe disability and increase in survival. Finally, in Finland, there was a study published that looked at ICD-10 codes for various diagnoses associated with mental and poor academic performance, which concluded that giving steroids to late preterm infants should be reconsidered because they found that for 4 out of the 10 ICD-10 codes that they looked at, they were significantly higher or more prevalent in the betamethasone group.
Before you keep going, I want to ask both Dr. Zupancic and Dr. Gyamfi-Bannerman about this sort of controversy. It's interesting, like we mentioned at the beginning, it's unique to have the dual perspectives here today between MFM and neonatology, just because when you were talking about the hypothesis of the follow-up trial, saying that the hypothesis was that the intervention would improve outcomes, I think, at least from my perspective as a neonatologist, when I saw that the follow-up study was published, I think I was definitely thinking of it almost in the opposite perspective of I want to just make sure that there isn't a signal of harm because of some of the stuff that's been published in the interim, because of the increased risk of hypoglycemia, which can be short-lived, but we do know that a single episode of hypoglycemia, if it's significant enough, can be associated with harm. So my perspective was very much maybe there are some short-term respiratory benefits, but what if steroid exposure in a population that's fairly well, regardless of whether they get steroids or not, puts them at higher risk of neurodevelopmental impairment?
Yeah, so I, obviously have a lot of thoughts about that, and I think so from our perspective, probably the best thing out there prior to this study was the middle one, the Charise meta-analysis, because there's so much confusion about steroid studies because after NICHD decided that steroids were safe, good to use after the 1994 consensus conference, people started studying multiple course steroids and weekly steroids and all of these things, which had signals for harm in multiple courses. So what they did was they looked at single exposure to steroids and found no difference. The ASTEX-2 study, which was all done at term, when you look at it, it's very interesting the way that the results are listed here, because when you look, they did a subjective, which was the teacher's assessment of the school performance, and they actually did objective indices as well, where they did I can't remember the name of the scale, but they did an objective index of neurodevelopment. There was no difference in the objective test of neurodevelopment, but everybody looks at the teacher's assessment, which even the authors concluded in their paper was flawed. I can tell you that my first grade teacher did not think that I was a very good student, even though I scored in the 99th percentile. So to me, Aztecs 2 showed no difference because clearly an objective test is better. Soteria, the Greek group, also the same. But really harmful, I think, to the literature was this last paper. Because even on your slide, it says that they received late preterm steroids. If you read the paper, they have no idea when the steroids were administered. They just happened to be born in the late preterm period. And the fact that I think that JAMA could even make them take that leap is really insane. There's a really great editorial to this. I mean, we wrote a letter to the editor. You could maybe argue that we're biased, to show that first, they don't know the gestational age when the steroids were received. They don't know, first of all, and they took out the children, obviously, that died, but they took them out of the analysis so that the people who were probably, so that the survivors essentially who would have lower neurodevelopment than the ones that died, like they didn't include death in their outcome, which they should have. But then there's a statistician, a European statistician, that goes through the paper and basically shows how those findings could totally be incorrect based off of the analysis that they did. But everyone still looks to this and they think that there's some association with late preterm steroids, which there actually is not. So really, really harmful types of papers that get people to think things in the absence of what I think was the important analysis, which was the analysis by randomized, participants.
Thank you for that.
Yeah, it's really important how to evaluate literature, and that's hope plan to
Yeah,
achieve through this journal club.
absolutely. Absolutely.
Before getting into the results of the follow-up study, I did want to also look at changes in practice since the ALPS trial was published. Dr. Gyamfi-Bannerman, as well as others, did a cross-sectional study looking at late preterm births in 382 referral hospital regions across the United States before publication of the ALPS trial and after. They showed that there were some parts of the country where there was faster adoption which was the darker blue here, compared to slower adoption in the darker red. Overall, though, since the time of the publication of the ALPS trial, there has been an overall increase in the percentage of late preterm infants exposed to prenatal corticosteroids. This cross-sectional study also looked at infants who were born in the late preterm period and looked at differences in maternal characteristics. So again, in the first graph, you'll see that there has been an increase in the percentage of women in the late preterm period who have received corticosteroids. There is some benefit, some decrease in the immediate need for assisted mechanical ventilation for those who receive prenatal corticosteroids, but there was no difference in ventilation use after 6 hours in either group, which is shown in the third graph here. So getting to the results of the follow-up study, so there was not a big difference in the maternal characteristics of the follow-up participants. There was also not a big difference in any of the characteristics here as well, including age, college degree, etc. There was, however, again, seen in the neonates that in the betamethasone group, there was a larger percentage of infants who experienced hypoglycemia. The number needed to harm in this case was similar to the parent trial, which was 10 compared to 11 in the parent trial. There was a slightly higher percentage of infants with major congenital anomalies in the placebo group as well. Race and ethnicity between the groups were also pretty similar. Apart from non-Hispanic Black, there was a higher percentage of infants or children in the non-Hispanic who identified as non-Hispanic Black in the placebo group. Looking at the primary outcome, the GAS-2 score of less than 85, there was not a statistically significant difference in neurodevelopmental outcomes in the betamethasone group compared to the placebo group. Here, the number needed to benefit is 71. So there is a trend towards betamethasone improving neurodevelopmental outcomes, in that there is a lower percentage of infants who have scores less than 85 in the betamethasone group at 82 compared to, or sorry, 17% compared to 18.5% in the placebo group. As far as the secondary outcomes, looking at the verbal ability, nonverbal reasoning, and spatial ability, there was no difference in this either. Looking at the child behavior checklist, which the families filled out, there was also no difference in internalizing behavior, externalizing behavior, or dysregulation between the groups. So some of the limitations, some of which we
we can just go through the results. So Dr. Zupancic, do you want to comment on the results of this study, and again, going through the number needed to treat and benefit, how should we as trainees put this into perspective?
Yeah, one of my advisors and mentors is Roger Saul, and he has for a long time talked about this idea that follow-up is essentially the establishing of a safety signal for many of our outcomes, particularly when they might have short-term outcomes that are appealing in some way. And regardless of the issue of hypoglycemia, which, as you've heard from Dr. Gyamfi-Bannerman, seems to be seems to have been addressed by her and other studies in other ways. But I think that to the extent that we can put the sample size and the power to one side, I think these are reassuring data. Essentially, once we get to numbers needed to treat that are up in the 60s and 70s, particularly with the confidence bounds that we see here, it's quite reassuring, right? It's smack in the middle of the confidence bound is quite symmetrical around 1. So I think and also the fact that this is the case with all of the primary and secondary outcomes, it's also reassuring. Obviously the power here is an issue, and although they Dr. Bannerman's group certainly did a post hoc power calculation that was actually pretty compelling. I think there was I think there was an 80% power in the end to detect a difference of 0.36, right, and or in that range, which is pretty good. But the problem obviously is the potential for selection bias in the particular patients who came. So it brings up this idea, I think, just that, and I wanted to ask you, Cynthia, had you thought at the time of designing the original trial of designing for this outcome? Because I think this is really useful. If the earlier outcomes had kind of been made a secondary outcome, and this had been powered to really show a compelling lack of safety issues, that might have removed any doubt about whether this was a safe therapy to institute.
Yeah, so the original iteration of this study included a 2-year follow-up, and that's what we were hoping to do. But if, for those of you who have tried to fund large clinical trials, the NICHD said that it was too expensive, and they weren't going to fund the follow-up right away. If we found a benefit, then it would be considered. But, and I should really say it was NHLBI who ultimately provided the majority of the funding. And we're very happy that they did, but they were not willing at the time to fund a follow-up. Actually, the first version of the study looked quite a bit different than the version that we completed. The follow-up, we absolutely were hoping to get more kids. I think obviously the pandemic really hurt us because the follow-up included a pulmonary component, which was kind of obviously separate from neurodevelopment, but parents and caregivers just were not willing to bring their children into the hospitals under really any circumstance. And some of these are challenging to do at home. So we did really try to find people and convince them. We definitely had a higher rate of people who were not necessarily willing to participate in research at that point. But from a statistical perspective, I think that when you have these point estimates that are 1.2, 1.3 towards harm, and we're saying there's no difference because we can't detect, less than, 36% or whatever. I think that that's very concerning. But when you have point estimates that are actually in the direction that you anticipated that they were in, including larger numbers of folks is not necessarily going to change your confidence around those point estimates. And so I do have to say that from that perspective, I think we were pretty comfortable in showing this. The other piece, frankly, is that we have all of these neurodevelopmental outcomes from Liggins and Howie, which was mostly late preterm kids. And it showed the same thing. And that's why we were pretty confident that if we could look at it from a randomized perspective, that we would see something similar.
So just
Thank you. Go ahead, Dr. Zupancic.
sorry, I was just going to say, just following on that discussion, I just wanted to make the learning point that attrition, follow-up is not just a matter of reducing the sample on which we are going to do the analysis, which is a statistical issue, but also the potential of introducing selection bias. And I think that the analysts in this case actually did some pretty harsh tests of selection bias in assigning every missing child to the worst outcome, which is very, a very significant test. But when you're thinking about this as trainees, think not only about what this does to the statistics, but what it does to study design as we lose patients in the longer run.
From very good points. Charise, you want to wrap up your slides?
Yeah. Just to touch on the secondary analyses a little bit, like Dr. Zupancic mentioned, the authors did do a sensitivity analysis, and when including patients who were lost to follow-up, they found very similar results to what was found in the baseline study. There was no difference in the sensitivity analysis that assumed that all lost to follow-up either had or didn't have the primary outcome. All right. So as far as discussions and limitations, we kind of have already talked about the power calculation and the fact that there was significant loss to follow-up between the original parent trial and the follow-up study. There were also small numbers of term infants, and although the study was mostly looking at late preterm infants, there was about 16% of the follow-up study that did include term infants. So it'll be interesting to know what the baseline characteristics of those term infants were compared to the late preterm infants. And this is a difficulty with the antenatal corticosteroid literature as well, that there's not a lot of good data on infants who ultimately get delivered at term. We kind of have already addressed the third limitation that I mentioned as well, knowing the characteristics of those hypoglycemic infants. I think this one is also an interesting one, especially in a multi-center trial who might have different criteria for admission to the NICU if you're hypoglycemic. So for example, at my home institution at UVA, all infants less than 35 weeks or less than 2 kilos get admitted to the NICU, and we don't have a special care nursery or an intermediate care nursery. And so even if we have a term infant who is requiring IV fluids, that still requires separation from the family and admission to the NICU for IV fluids, which can be considered a harm as well, especially in that early peripartum period, which can be difficult for moms and families. Another limitation was the instruments used to evaluate neurodevelopment. So there are other studies that have looked at, for example, the Bailey scales for infant and toddler development at 2 years of age, and looking at using that as an objective scale for measuring neurodevelopmental outcomes. But again, there's not an agreed upon neurodevelopmental evaluation tool that is used universally. And so some of these tools can miss some more subtle neurodevelopmental findings. Does anyone have anything else they would like to add on the limitations?
Yeah, I mean, I think it's interesting because, yeah, like you said, 16% of our infants went to term, and we did the sub-analysis on the term infants. There was no difference. We actually presented this year at SMFM, so back in February, the outcomes of the hypoglycemic infants. So looking specifically at neurodevelopment for all of the late preterm infants who had hypoglycemia compared to all of those who did not. Again, just, commenting on, we showed before that the hypoglycemia is pretty short-lived, but found no differences there. And I just have not had the time to write up that paper. There's a draft, but I'm working on that. So that'll come out in the literature. But the Aztecs trial, which you showed, was only in term infants. And so actually we have a lot of data on term infants with steroids. And you can see there that there was no difference, again, when you look at the objective actual testing. And for Liggins and Howie, 34% of their infants were delivered at term. So most of the survivors, obviously in the 70s, were late preterm. And so that's, again, a lot of data, I think, for that.
Can I just add one thing about these babies who continue on without delivering late preterm, and it's related to the concept that our inclusion criteria for trials, certainly in neonatology, I don't know the obstetric literature as well, tend to be very blunt. We don't use precision medicine to decide who gets into a trial, and it seems to me that if you had a test and knew exactly the likelihood of a patient delivering in the next week, you would be the ratio of number needed to have in some kind of adverse event to the number needed to benefit would shrink, right? So the question I had for you is since the time that this trial was developed, do we have any better way of narrowing the entrance to the trial beyond just gestational age with preterm labor, basically, to patients who you think are very likely to deliver, basically applying a precision filter to the inclusion criteria? And do you think that would have been helpful or could be helpful in clinical practice?
No, actually, we not only do we not, but I think we're moving further and further away from understanding preterm birth at all, because a lot of the treatments that we're trying to use that in the preventative route have not been found to be helpful. So actually, one of my other hats is that I'm the president for the Society for Maternal Fetal Medicine. And in our next annual meeting, which will happen in end of January, early February, the president's workshop is going to be about preterm birth, because we still, there's so many questions that we haven't answered. And one of them is exactly that. We still don't know how to precisely identify a pregnancy that will deliver within a week. It's important for steroids, it's important for management, it's important for neonatal outcomes. And then kind of the alternative question, which is something that, we tried to ask also is which infants are going to be at risk for respiratory distress? You have 2 34-weekers, one does perfectly fine, and one spends a month in the NICU. And it's not the easiest thing right now to tell a priori who that's going to be. So, I mean, those are some very wide open questions that I think we need the answer to. We used to use fetal fibronectin, for some of you who might remember that, to help us predict who would deliver within 2 weeks or outside of 2 weeks. And even that has fallen out of favor. So we really are not great at figuring out, number one, who will deliver, and number two, which children will have respiratory morbidity.
I think there's a great point raised by Dr. Zupancic. Surely the number needed to treat and number needed to harm ratio will move in a favorable direction towards late preterm and steroids if we can identify the babies who is gonna deliver in the next week or so for it. So Dr. Zupancic and Charise has presented the economic analysis and the economic expert for this. So how would you put that data into perspective about recommending steroids for the late preterm population, solely looking at the economic benefits this intervention offers?
Yeah, I think it's become obvious over many years and many economic evaluations that with something that is as expensive as neonatal intensive care, if we have an intervention that works to improve outcomes and that improve the time in the NICU, then almost always it's economically a good idea. Even very expensive interventions tend to be economically viable within what we would be willing to pay to avoid a expensive outcome. And in some cases, as was the case with the initial trial, it was already cost saving even before we knew that there was no worsening of economic outcomes. So I would say that in general, the economics we should apply it kind of after we have established the clinical risks and benefits as part of the policy adoption decision. And usually if something is effective, it will be economically desirable. But in any case, it should be a matter of is it feasible economically, and what are we willing to pay to achieve a good outcome in cases where there is a good outcome. I think in this case, the follow-up study doesn't change what in an economic way what Dr. Gyamfi-Bannerman established with the cost paper earlier on. It was already cost effective, and this basically just removes the uncertainty about whether hypoglycemia would have increased costs over the long run, which we're not seeing here.
Thank you so much. So before we move to our final closing comments, just a quick poll for the audience members, and then we can take some questions from the audience. So taking some questions from the audience, as said, we were initially discussing about what outcomes are important at that time. In 2009, these were the important outcomes, but times have changed in past 15 years. They said admission to the NICU is traumatic for parents, even if the problems are not medically consequential for neonatologists, which is an important point. And I think as neonatology, we're also moving towards the ranking of outcomes and those analysis. Dr. Zupancic, you want to comment on any future trials which needs to be designed with this in mind, how the outcome should be weighed?
I think that's a very good point, and I'm particularly appreciate the opportunity to respond to this because this came up when I inartfully used the word or the phrase non-serious versus serious outcomes, which I was thinking of in biological terms. The outcomes that are important to parents are often very different from the outcomes that we think are important for purposes of categorizing research results. Annie Janvier gave a parent colleague of hers, whose name is escaping me now, I'm sorry, gave an excellent presentation at PAS last year about the need to transition our trial outcomes to functional outcomes that were relevant. So for example, not BPD defined by O2 at 36 weeks, but rather, can my child keep up playing soccer at 4 years of age? And not necessarily a Wechsler scale of 80, 88 or 92, but rather is my child able to achieve school outcomes that are appropriate for her. So I think that comes to Brian's question about involving parents in the generation of or in thinking about outcomes, and I think our whole literature is going to move towards using those as primary outcomes now, rather than just having parents help us to kind of inform the nuances of outcomes we've already decided on in a list.
I think to address one of the primary questions that were in the chat, and there has been some addressing of it in the chat, but I'm going to pull out one particular sentence from Dr. Camp saying, where he, in one of his responses, said, showing no purported differences in neurodevelopmental outcomes fails to inspire confidence in a therapy that, in essence, modestly prevent a largely non-morbid disease. And I do think that does reflect opinions that I've seen, and maybe in some way I am in some ways aligned with that. And I've even heard it directly from MFM colleagues that have said, when we're discussing a mom who's going to deliver 34, 35 weeks, and they're like, oh, well, we didn't offer steroids because all it's going to do is reduce CPAP. It's not really changing important outcomes, so we didn't talk about it. And so I think I think this follow-up study was incredibly important to show that there is essentially no signal in either direction, which is good. But then it does make us fall back on those primary outcomes, which, or the primary study, which, yes, the hypoglycemia was short-lived, but so was a lot of the respiratory symptomatology. NICU admissions weren't different, but then that also varies by center. You do wonder if there's a potential for selective use of this therapy. If you're a center that doesn't automatically admit babies that are 35 weeks to the NICU, maybe in that subpopulation, it would have had a different effect on a NICU admission rates. Just weighing those two things, Dr. Zupancic, Charise, and Dr. Jane, like all of us here, I'm wondering how we are responding to this poll. Like, what do you feel about the balance of those two outcomes? Is a brief period of CPAP better or worse than potentially a brief period of hypoglycemia, maybe requiring an IV for a few of them?
Maybe Dr. Brackett, do you want to?
I can take that. I will say that I kind of take kind of like we've already been talking about here, like what truly matters to the family. And I think about like a baby who is needing CPAP or high flow. Like a lot of times in our unit, families feel very uncomfortable with even holding their baby or doing skin to skin versus like if they needed an IV for IV fluids, like there's nothing on their face. I feel like the family experience around like needing to be admitted to the NICU in the late preterm period, although there wasn't a significant difference in needing respiratory support, I feel like is also an important thing to think about. I will say that because we at UVA typically will not admit infants who are born after 35 weeks to the NICU as a matter of protocol. I think being able to start feeds earlier and hopefully help to treat some of that hypoglycemia. I think without, needing NICU admission, I think that is significant and important as well.
Yeah. So as we can go through the poll results, about 40% routinely use steroids in the late preterm populations. And having said that, about 60% would recommend their OB based on today's discussion about how to evaluate literature using this. So I'm a basic scientist who trained under Dr. Job and worked with steroids and its effects and stuff. So, and looking at evidence-based medicine, should we base a recommendation of what we think is going to happen, or we use the data which we clearly have in front of us and recommend treatment to our families based on the data we have until new data comes for it? So Dr. Bannerman, do you have any comments on this? What would you push this forward to showing that this is the best data we have until, it took you 10 years to do all the analysis and trial, and this will be a very long time till we get a better study to explore this with the outcomes such as NICU admissions and other things which matter for parents and not much for neonatologists come into play?
Yeah, I mean, I think, NICU admissions were similar, but the length of stay was definitely longer in the placebo group. I think that, and I think one of the reasons we designed the outcome, and I think Charise has kind of mentioned this, is because we wanted an outcome that separated mom from baby. That was one of the things we were thinking about. So even though we didn't have parents involved in that outcome, that was what we were thinking about, because we knew that that would affect breastfeeding and all types of downstream effects. So in thinking about whether it was a strong outcome, that we kind of left to the neonatologist in terms of how long is of oxygen, or some of these other things are too long. And we looked at all of those. So, I mean, I don't think, I don't see a world in which we would kind of redesign this trial solely to look at NICU. But I do think, when we designed this, we were really thoughtful about looking at all of the data on neurodevelopment. And again, on the preclinical level, on the basic science level, those studies that have shown that there's some potential, something that might be there, haven't changed since the 70s. But on the clinical level, they've actually never been shown. And so it would be really, as a scientist, as a physician scientist, I can show you what the data are. There are some people who have very strong feelings about this and, are going to go one way or another. I know them all. But these are the data. It's safe in this group, but it was also safe in the meta-analyses. It was safe in the ligands and Howie kind of long-term outcomes. And so I don't necessarily think that we're going to be able to do something like this again. Certainly, I think some folks can look at it. My understanding is that there's another study which will be presented in SMFM in 2025 that hopefully also looks at late preterm steroids. So lots of data coming out, but I'm not sure with the challenges, and of course the pandemic did mess us up a little bit, but with the challenges of doing this whole thing, which took us about 12 years, I don't know that it'll happen again.
Dr. Zupancic, do you have any final closing comments on this trials and how trainees should adopt this in their practice, given all things we have learned regarding outcome, the cost benefits, and no difference in the outcomes, neurodevelopmental?
I'd say a couple of things. First, I would just take the opportunity, because I don't think I've ever had the opportunity in public to thank Cynthia for doing something that's at the intersection of neonatology and obstetrics. I don't think that we do that enough. And as she did this, she really involved neonatologists in several of the steps, and we could learn from that as in our neonatology trial literature. The other thing I would just come to is that putting aside the specific issues of late preterm steroids, I think a lot of what we've been discussing today is relevant to patient populations that might be lower acuity, who might benefit from a therapy, but in whom risks loom large. And I think that in that population, going forward with therapies, it may be a good idea to think about designing a trial that primarily excludes harm. And then, as said, and then once we've done that, we can say, look at these secondary positive, effect outcomes that we might benefit from. And in that case, we would not be having much of the discussion we were having today, which is, this seems like a good thing for families, but we're uncertain about the long term. We would flip it around and say, this is safe. Is it worth it to prevent separation of moms or birthing parents and their babies? So I would just say that these sorts of discussions give us the opportunity to redesign the trial approach in a way that we haven't necessarily thought about doing previously, and think about harms as outcomes that we prioritize.
So I think there's a lot of great learning points for the trainees who's going to be future trialists and going to design some trials for it. It was an excellent presentation, Charise. It was very well laid out. We're very grateful for you. And just any more final closing comments, Dr. Bannerman, if you have for us neonatologists. It was a pleasure having OBGYN come to us neonatologists and give their side of things.
No, the only thing I have to say is, again, thank you so much for inviting me. And I agree. I mean, John and I talk about this sometimes. We should get together more. Obstetricians, MFMs, neonatologists. I mean, what we do directly affects each other, and we should really have more dialogue about it. So this is a great opportunity, and I really appreciate you for inviting me to speak.
Maybe we can have some of your fellows presenting here. And
Yeah, that'll be great.
might be
We'll
great.
like to know what outcomes are, because as we have seen, like the respiratory support may not be a very important outcome for some of the neonatologists or majority of the neonatologists, but having the other perspective of OBGYN and what they think would be very helpful. Well, thank you everyone for joining us on a Friday evening and spending time with us. Our next session is on the MINME trial on October 31st, Halloween. We'll hope to see you back again soon. Thank you so much. Thank you, Dr. Zupancic. Thank you, Dr. Bannerman. And thank you, Charise, for the wonderful presentation.
Thank you. Thank you so much for having me.
Bye.
Take care, guys. Thank you.